So you walk into the first patient's room and you notice that the leg is swollen and painful. And you wonder, what is it that you're supposed to do? What workup do they need?
In the next room, you have a patient with Crohn's disease who recently returned from a camping trip presenting with bloody diarrhea. And you wonder, could this just be a Crohn flare or something else like an infectious diarrhea?
In this episode of Critical Decisions in Emergency Medicine, we will talk about deep vein thrombosis, specifically the diagnosis and management.
We will also discuss bowel conditions, including giardiasis, Crohn's disease, as well as Meckel diverticulum.
With you is Dr. Danya Koja. I'm an emergency physician who practices in Florida.
And this is Dr. Wendy Chang, an emergency physician and neurointensivist in the Baltimore, Washington area.
And this is the July episode of Critical Decisions in Emergency Medicine podcast. And each month on the podcast, we discuss the Critical Decision publication. In each publication, there are 2 lessons that cover either bread and butter emergency medicine or things that are cutting edge.
In addition to the 2 lessons, there are also a lot of other features, such as the critical cases in orthopedics and trauma, the clinical pediatrics, and as our listeners know, my favorite, the literature review.
So let's jump into our first lesson, legwork, emergency diagnosis and treatment of deep vein thrombosis. Thank you to Doctors Richard Jean-Louis and Kinjal Sitharaman for writing this article. And we have a surprise. Dr. Richard is with us here on this podcast.
So Richard, tell us more about you.
Of course, first and foremost, thank you so much, Dr. Chang and Dr. Koja, for welcoming me to your platform. A little bit about me. I am a recent graduate of the University of Maryland's Emergency Medicine Residency Training Program, and I am currently an assistant professor at Wake Forest University in their ED.
Excellent. So tell us a little bit about why you decided to write this article.
Of course. So DVTs, PEs, which all fall under the umbrella of VTE, venous thromboembolism, are relatively common maladies that we experience in the emergency department that have consequences and sequelae that can be potentially fatal. This disease process, known as VTE, affects approximately 900,000 Americans annually. Additionally, approximately 10% of those result in death from VTE. We've known a lot about VTEs since it was first documented in the 1200s, but there continues to be research in the therapeutic modalities and diagnostic approaches to VTE.
Those are all really great reasons and kind of scary reasons, actually, to be talking about this. So let's start with the basics. We know that a typical DVT presentation is unilateral limb swelling, pain, and erythema, especially in a patient who's high risk. Any pearls you want to share with us that we should remember?
Sure. So one of the main pearls is 7% of DVTs are actually bilateral. So those patients who come with bilateral or extremity pain and the differential is heart failure, liver failure, nephrotic syndrome, I think it may be important to keep that in the back of your mind. If everything else looks normal, consider that 7% of DVTs are actually bilateral. Additionally, the Homan sign, that maneuver we all learned during medical school where you dorsiflex the foot and it elicits pain in the posterior calf, has low sensitivity as well as a low specificity. The sensitivity in studies is documented anywhere from 10 to 50%, where the specificity is documented at 30 to 90%. With that big of a range, it's not that great. So I would trust the physical exam, the HPI, amongst other things, in determining if the patient has a VTE, specifically a DVT. Additionally, it's important to perform a thorough physical exam, getting a general sense of how the limb looks. Is it red? Is it warm? Is it painful? Is it swollen? Additionally, assess to see if there's hyperesthesia. Check the neurovascular status. What is the CAT refill? And another thing, specifically when you're considering a DVT, is assess areas for cords. So palpate in the popliteal fossa, look in the groin. You may feel something, and that can increase your suspicion for a DVT.
Great points. So who's really at risk for these DVTs?
Sure. So going back to the basics, Virchow's triad, we've all learned about it: stasis, hypercoagulability, and endothelial damage. Going through each of those major risk factors, stasis, low flow, includes surgeries in the past 3 months, especially orthopedic surgeries. Anything that can cause immobility will raise your risk of developing a DVT. Additionally, CHF and long travel carry high risk factors for developing of DVT. A long haul flight is anything described as a distance of 10,000 kilometers or more. So that's actually a flight from Chicago to Tokyo without any layovers, puts you at a higher risk of getting a DVT, specifically during the hazard period. Now, the hazard period is defined as any period within 2 weeks of that long haul travel where you're at a fourfold increased risk of developing a deep vein thrombosis. So I feel like that information is extremely important when ascertaining HPI in a patient coming in with limb swelling. In terms of the hypercoagulability, there are multiple disease states and medications that can put you at risk for developing blood clots. Some of these medications include exogenous hormones, chemotherapy, and some of those disease states that can raise your risk for a DVT include malignancy, a personal or family history of prior DVTs, pregnancy, and smoking. It is important to realize that these risk factors are synergistic, so the presence of two or more can put you at a dramatically higher risk. And in terms of endothelial damage, anything that is damaging blood vessels can cause this, specifically veins. So patients who are getting frequent IVs, especially ultrasound guided IVs, individuals who donate plasma, those sorts of things put you at very high risk for developing deep vein thromboses.
Wow, that's quite interesting about people who donate plasma. So let's just circle back and talk a little bit more about these hypercoagulable states, because it's honestly not that common for people to know that they have these diseases. They just show up to the ED, and then 6 months later, people figure this out.
That is an excellent point. It is actually relatively common for the first time presentation of these chronic diseases to be a DVT. So, in patients who present with DVTs of unknown etiology, they generally get a very broad workup to determine the cause of that, to determine whether this was provoked or unprovoked. The disease states that we know of that carry high risk of developing DVTs include factor V laden, antithrombin 3 deficiency, proteins C and S deficiency, May-Thurner syndrome, HIV, and lupus. So going through a few of these disease states individually, factor V Leiden is actually the most common inherited thrombophilia in the United States. One study found that 21% of patients with DVTs actually had the mutation for factor V Leiden. Antithrombin 3 deficiency causes both PEs, DVTs, as well as ischemic strokes. There are two types, congenital and acquired. Congenital, you're born with it. There's some mutation. There's really not much more to add about that standpoint. However, there can be acquired antithrombin 3 deficiency. Any disease state that causes spilling or damage or decreased production of antithrombin 3 can put you at risk of having this acquired deficiency. So renal failure, liver disease, as well as malnutrition put you at risk of developing acquired antithrombin 3 deficiency. May-Thurner syndrome is a unique condition where patients can develop iliofemoral DVTs, which is secondary to compression of the right iliac common artery, just based on its curvature and angle coming down into the pelvic region, which causes a mechanical obstruction, resulting in DVTs, which can present in actually 2 to 5% of DVTs.
That was a great review. The article definitely has more details about these hypercoagulable conditions for sure. But what about fat embolism? Does that play a role?
Excellent question. So, fat embolism are a little bit different. They usually occur from long bone fractures, and their presentation typically follows a triad of petechiae, dyspnea, and alternate mental status, usually following a long bone fracture like a femur fracture or a humerus fracture. Fat emboli, relatively uncommon, and they're treated supportively. However, if the patient is undifferentiated, it is reasonable to give them TPA if they're in a critical state.
All right, well, that was a great review of the basics. And we all know that with DVTs, we worry about PE as a potential complication. But are there any significant local complications we need to be thinking about?
Of course. So as you mentioned, PEs, it's the feared complication, right? That tachycardic tachypnic hypoxic patient who looks very ill with a history of DVTs. We're all concerned. But as you mentioned, there are other consequences and sequelae of DVTs that don't involve the lungs. Some of these consequences include phlegmasia alba dolens and phlegmasia ceruleus dolens. So very complicated words, but if I could translate them, for you all, phlegmasia alba dolens, also known as milk-like syndrome, is when you have a pale, edematous, painful lower extremity, which is indicative of a large DVT that occurs in a large vein, but spares the collateral venous circulation. So you will still get some of that venous blood flow. Phlegmasia ceruleus dolens, also known as copper leg, presents as lymphcyanosis, pain, swelling, and this is when the collateral vessels as well as the large vessels are obstructed. Both of these conditions are exceptionally rare, but carry a very high mortality rate. The mortality is secondary to gangrene that develops from all that obstructive blood flow with septic shock. These are things that need to be evaluated in patients who have limb swelling. How bad is the pain? What is the color of the leg? Do that thorough exam and make sure you are ruling out these diagnoses. On a milder spectrum for DVTs, long term, up to 50% of patients who have deep vein thromboses can actually develop something called the post-thrombotic syndrome, formerly known as post-phlebitic syndrome. The vascular damage resulting in venous insufficiency can cause chronic pain. So it's not uncommon for these patients to come in reporting pain in the lower extremities where they've had affected limbs from DVTs with negative DVT studies. It is just something to be aware of for both providers when working patients up, as well as for them to tell patients at the time of discharge, this may be in their future that they have chronic pain.
That's super interesting. And thank you for the Latin lesson, because I don't think I ever knew exactly what the words meant. So let's now talk a little bit about working up for DVTs and ED.
Sure. So there are several pathways to diagnose a DVT. Some involve pretest probability tools, others clinical gestalt, but in general, there have been several scoring tools that have been well studied and validated to assess DVT risk. Some of these tools include the Padua score for DVT risk, the Caprini score for predicting DVTs in surgical patients, as well as the modified and original Wells criteria for DVT.
Wow. I usually just think of the modified Wells criteria since it's the one we most commonly use, but turns out there's quite a lot more. But let's talk about modified Wells criteria, shall we?
We shall. For the modified Wells criteria, there are 10 parameters, each weighted differently, that determine the pre-test probability for a patient having a DVT and requiring a D-dimer and or an ultrasound. So for a score that equates to unlikely, the DVT prevalence in this population is 5% or less. The moderate group has a 17% prevalence, while the high risk group has a 53% prevalence. If unlikely, there is no workup that is required. However, if there is a moderate high likelihood, you may have to do a little bit more of a workup. For your moderate patients, a D-dimer can rule out DVT in 99% of those patients, whereas a high probability patient, you would go straight to ultrasound. Additionally, it's important to know which kind of D-dimer assay your facility uses because different assays have different sensitivities, but more on that in my paper if you're interested.
Those are great pearls. What about ultrasound? Surely we use that a lot.
We do. We all love ultrasound. It's cutting edge technology that's extremely integral to the work that we do as clinicians. For DVT diagnosis, there are two common modalities for ultrasound to rule in or rule out a deep vein thrombosis. They all use the linear array transducer, but they operate a little bit differently. For compression ultrasonography, it is compression of the proximal deep veins, which include the femoral, and the popliteal veins that are being scanned. With the duplex ultrasound, the whole leg is scanned. It also uses Doppler and B modes, which provide more sensitivity through this modality. It is a little more time consuming in comparison to compression ultrasonography, but it's more successful in ruling out DVTs. If you are using compression ultrasonography and it does not show a DVT and you are still clinically suspicious, that patient must come back in 1 week's time for a repeat ultrasound. If you are using duplex ultrasonography and there does not seem to be a DVT, the patient does not require additional imaging.
Great, Pearl. So let's say we did all of these workups and the conclusion we got to was that the patient has a DVT. What are we supposed to do?
Of course, the goal of treating most DVTs is to prevent extension of the blood clot and subsequent embolization into the lungs, i.e., pulmonary embolism. However, it really determines on the location and the severity of the DVT, which will guide how you treat this patient. Most patients can be started on anticoagulation. However, there is a small subsegment of these patients who may require mechanical thrombectomy. Chest guidelines from 2021 strongly recommend that lower extremity DVTs distal to the popliteal vein can be managed by serial imaging without any anticoagulation, unless follow-up imaging shows extension into proximal veins or distal progression. Anticoagulation is a modality that can commonly be used, and we already spoke about mechanical thrombectomy being potentially used for certain candidates.
Let's talk a little bit more about anticoagulation. There's so many choices.
Of course, traditionally, conventionally, anticoagulation consisted of a heparin infusion with a bridge to vitamin K antagonists such as warfarin. However, with the advent of DOACs, including rivaroxaban, apixaban, dabigatran, oral anticoagulants have largely replaced the heparin to warfarin bridge. However, we need to be aware of the special populations where the conventional treatments still are first line. So some of these special population patients include pregnant patients with DVTs who should be treated with heparin per ACOG guidelines. Furthermore, patients who have cancer should be treated with low molecular weight heparin. Additionally, CHEST recommends that patients who have a history of antiphospholipid syndrome should be treated with vitamin K antagonists. So these special patient populations are very important to be aware of when you're thinking of treating your patients for DVTs and PEs.
Great pearls on treatment. So, with all of what you just said, do we have to admit all of these patients with a DVT to start them on this anticoagulation?
I'm happy that you asked. The answer is no. Not every patient who is diagnosed with an acute DVT requires hospitalization. However, it is important to go through a long list of things before safely discharging these patients. It's important to know the patient's social determinants of health. Do they have access to Medicare or Medicaid? Will they be able to fill out the prescriptions if you start them on a DOAC? And are they reliable enough to take those medications to prevent high risk DVTs from propagating in their venous system? Once that's sorted out, it's important to assess the bleeding risk of these patients. So the HAS-BLED score has been developed to determine major bleeding risk on patients started on anticoagulants in AFib. We can actually adapt that to patients with DVTs, and studies have shown it. More details in my article if you're interested. So any positive point in the HAS-BLED score means you have a higher risk of major bleeding events from anticoagulation. These patients may need to be admitted, started on anticoagulation, and monitored to deem them fit for outpatient management. Additionally, as mentioned before, patients who have proximal DVTs of the lower extremity may be candidates for mechanical thrombectomy, especially those who are presenting with symptoms concerning for phlegmasia alba dolens and phlegmasia cerulean dolens.
That's such a useful tool in terms of assessing the bleeding risk. And Obviously, a great review of a common condition we all see in ED. What are your take home points for our listeners?
Of course. So we hit on a few pearls during this podcast, but if I could sort of tie things together and highlight some of the aspects that I'd like to drive home again, DVTs are relatively common. It's things we'll all see in our career as clinicians in the emergency department. And we always have to have a high index of suspicion of DVTs, especially when patients are presenting with both atraumatic and traumatic limb swelling. Just a quick story to sort of tie that point. I recently had a patient who came into the emergency department who was deadlifting, felt a pop in his thigh, and for about 4 or 5 days, he was bedridden. He comes to the ED, he has significant pain in the lower extremity, and I assess his thigh, and he has quite a bit of swelling. So I get a CT scan to assess for like a gastroc rupture or something concerning like an expanding hematoma. And he had both a ruptured quadricep muscle as well as a DVT extending from the popliteal up to the femoral. So you can have both. These conditions do not occur in isolation. Another pearl and thing to keep in mind is that complications of DVTs exist on a spectrum. They could result in a PE, it could result in those two catastrophic gangrenous venous obstructive states that I spoke about, but it could always cause chronic pain. So knowing the spectrum of disease that DVTs can cause is imperative to how we manage our patients. Several scoring tools exist in determining pretest probability in D-dimer patients. Several scoring tools exist in helping us determine pretest probability for DVT patients. Duplex ultrasound is the gold standard of diagnosis. However, compression ultrasonography can be utilized if Doppler and B modes are not modalities present on your ultrasound device. DOACs are extremely integral in DVT treatment. However, there are special patient populations that require conventional and traditional treatments for DVTs.
Well, thank you so much, Richard, for a great summary that is filled with pearls. Although we think DVT is a simple topic, there's so much that we can learn.
Thank you so much for having me. I really appreciate the opportunity to discuss this very important topic, and I look forward to future discussions with both of you.
Yes, indeed. Thank you.
Moving on to a different topic, our critical ECG this month is an ECG with sinus rhythm with PVCs, a run of non-sustained VTAC, and LA-LL lead reversal. This patient is coming in with palpitations, and his EKG shows a lot of abnormalities. The PVCs are right there, kind of obvious. We do see some retrograde P waves as well in leads V1 to V3. The interesting thing is that we also find the lead reversal for the left arm and left leg, which we reviewed last month. That is definitely important to think of if you see prominent P waves in lead 1 compared to lead 2, which would not be normal in a normal sinus rhythm. There is a great table in this article that shows what the findings are that are associated with a lead reversal, so you can pick that up. Because I'm not sure about you, but I have been burnt before with EKGs that are with dynamic changes, when in reality the only dynamic change was that the leads have been reversed. Continuing our discussion on cardiovascular emergencies, our literature review this month is talking about outpatient treatment for low-risk pulmonary embolism. And we are reviewing the article by Morgan et al. That was published in Academic Emergency Medicine in 2021 that's entitled Outpatient Treatment of Low-Risk Pulmonary Embolism in the Era of Direct Oral Anticoagulants, a systematic review. Definitely an interesting topic because we sometimes just want to discharge these PE patients home, but how could we do that?
I have great news for you, though. We can do that. So, historically, we often admitted new diagnoses of pulmonary embolism to really initiate anticoagulation with heparin or low molecular weight heparin, ultimately bridging to warfarin as the long term AC plan. But data suggests that low risk PE, if you identify them using the PESI score or the Hestia criteria, can actually be managed outpatient. These are generally patients with normal vital signs, no respiratory distress, no O2 requirement, or right heart dysfunction. Currently, the direct Oral anticoagulants is the leading outpatient therapy for venous thromboembolism now. And this systematic review found that out of more than 1,800 patients, there was a less than 1% risk of major adverse outcomes, such as mortality, recurrent VTE, or major bleeding.
Definitely a new way to look at an old problem, I guess. So definitely check this out and see if that fits in with your setting and is something that we can actually start working towards. Now, switching gears to traumatic injuries, our critical case in orthopedics and trauma this month is about bilateral patellar tendon rupture.
This is a case of a 42-year-old woman who had a prior patellar tendon injury, who's now presenting with increased knee pain, swelling, and not able to ambulate. You find that she actually cannot extend her knees, and her x rays end up showing high riding patellas.
Thankfully, a rare disease that you'd have bilateral patellar tendon tears at the same time. These patients may present with a palpable or visible defect of the knee, and there's a pretty great figure in the article itself. And something important to consider in these cases is a systemic disorder, because why else would these tendons tear at the same time? Things like lupus or chronic renal failure, other things are age, fluoroquinolones, so that Cipro that everybody gives for that UTI, steroids, and testosterone use. Ultrasound or MRI are quite useful since incomplete tears may not be visualized on x-rays. And this article has a fantastic description and a bunch of images for these ultrasound findings that can help make your life easy. Because us explaining it on a podcast is probably not going to help.
We don't have ultrasound vision all the time as emergency physicians.
That would be a fantastic skip. However, speaking of images, our critical image this month is of urinary retention in a child.
Yeah, this was a case of an adolescent girl who presented with urinary retention and constipation. And urinary retention is actually quite rare in children. So we do have to have a broad differential considering neurologic, infectious, structural problems that are causing obstructions, as well as medication induced etiologies.
Yeah, it does seem that retention is not the problem with children. It's more like peeing everywhere.
That's right.
Something we have to keep in mind is that when we're thinking of constipation, we often obtain abdominal x-rays to evaluate for that, although we know that there's very poor diagnostic accuracy, and it's not recommended by society guidelines. And in this patient, that's actually what happened. They got that x-ray for the constipation, and she had a non-obstructive bowel pattern, but also the interesting part is that she had a density in the pelvis. When they saw that, they got a transabdominal ultrasound, which revealed an enlarged lower uterine segment, and her vagina was actually filled with hypoechoic fluid. The interesting part, she was found to have an imperforate hymen, which caused the retained menstrual blood and urinary obstruction to lead to that urinary retention. So definitely an interesting diagnosis.
Yes, definitely. The images are quite interesting.
Our critical procedure this month is about emergency needle decompression, which is one of the life-saving procedures that we do in emergency medicine. Risks include causing a pneumothorax or hemothorax if there wasn't one to begin with, injury to the neurovascular bundle, or injury to other structures in the area like the liver, the spleen, the diaphragm if the needle is not placed correctly. And then obviously the clear alternative to the emergency needle decompression is to actually just place a chest tube if you have the luxury of time and you actually have that easily accessible to you. What are some tips, though, for this procedure, Wendy?
Well, many of us learned to use the second intercostal space at the midclavicular line as the spot to do the needle decompression. But as we know from literature, as well as probably even personal experience, that there is quite a high failure rate, up to more than a third of cases, because unfortunately of increased chest wall thickness due to patient's body habitus. The key is to use a large and long enough needle or angiocath that are at least greater than 5 centimeters in length. So, for example, if you have like an 8 centimeter, 14 or 16 gauge needle or angiocath, that would be more likely to be successful. An alternative, though, is to use the fourth or fifth intercostal space at the anterior axillary line as if where you're going to place a chest tube and use a needle decompression at that spot. So you can attach a syringe and aspirate during advancing the needle or the angiocath, to confirm that you reached the pleural space to reduce the risk of injury. This is definitely the recommended this is the recommended location though in small children because the anterior chest wall area is more proximal to the heart and the thymus, and we would not want to cause injury to those structures.
I think that sounds like fantastic advice in general to not poke anything at the heart, but definitely a reminder that we may actually have to change that location in non-children. Speaking of children, though, our clinical pediatrics this month is a case of an adolescent who's coming in with a new onset seizure. This is a case of a child who's coming in with a recent red eye with subsequent fever, altered mental status, and a first-time seizure. Their exam shows swelling and redness of the right upper and lower eyelids, but no proptosis, no purulence. Their pupils are reactive, and their GCS was only 10. The diagnosis was actually for them to eventually they were found to have cerebral edema, subdural empyema, and right pansinusitis. Definitely a scary presentation of that sinusitis. Now, the presentation of that sinusitis can vary between children of different ages. Your younger children typically present with a cough, a mucopurulent nasal secretion. With older kids, they can have a little bit more of that facial pressure, the headache. What we need to remember is that there are several types of complications for sinusitis: orbital, osseous, or intracranial. The orbital complications are the one we think of often because they are the most common, and around 60 to 75%. And they can range from preseptal cellulitis to cavernous sinus thrombosis. Osseous complications include osteomyelitis, such as puffy tumor. An intracranial complication, like our case here, can include meningitis and intracranial abscess.
Definitely very scary. And a subdural empyema is actually the most common intracranial complication of sinusitis. Children in general have a greater risk of developing this from bacterial sinusitis because of the increased vascularity of their sinuses. And then, of course, if they've had prior head trauma or surgery to their skull and brain of some sort, that can, of course, increase their risk. We're usually dealing with polymicrobial organisms. And so you do want to treat with third generation cephalosporin, metronidazole, and vancomycin. And as in this case, oftentimes these patients can have other neurological complications such as seizures and altered mental status, and can have long-term morbidity, including cognitive problems, and can have long-term cognitive and neurological deficits. Another treatment that you can consider is steroids to reduce the swelling, but this is kind of controversial. And of course, surgical intervention should be discussed, whether this is a neurosurgery or ENT type of a co-management, since there's the sinusitis to address as well as the subdural empyema to address as well.
Great pearls on managing a condition that is hopefully not common. So switching over to a completely different system, our second lesson of this issue is gut wrenching. Small bowel, big problems. Thank you to Drs. Tyler Stannard, Stephen Rogers, and Rebecca Kernan for writing this article. We've talked about travel-related illnesses in the past. We've talked about Crohn's disease, diverticulum, and it kind of sounds like they're not really related. So why are they important, and why are we talking about them again?
I can't say that these three conditions are generally on the same differential diagnosis for a patient presenting with GI symptoms, but giardiasis is the most common intestinal protozoal infection worldwide, while ED visits for Crohn's disease rising, and mecodiverticulum is the most common cause of pediatric GI bleeding. So, being that these are quite common conditions with rising ED visits, we're likely to encounter one, if not all of them, on a shift. Maybe not in the same patient, but across the patients you see.
I would really hope that they're not all in the same patient, because that would just not be a good day for them. So let's start with giardiasis. Who is at risk?
Yeah, so this does require a review, at least for myself when I was reading this article about the parasite's life cycle and pathophysiology. So Giardia does exist in two forms, that trophozoite and the cyst. And the cyst is the infectious part that is passed through the GI tract, whether by humans, cats, dogs, and cattle. It's usually transmitted by water, such as from unfiltered water in endemic areas, but it can also be transmitted by other fecal oral routes, such as with poor hand hygiene, hopefully not at a daycare. And after the cyst is ingested, these trophozoites are released in the small intestine, and they're what they cause the damage to the bowel linings and the host immune response. Ultimately, the cycle repeats because these trophozoites travel to the colon, become enclosed in cyst again, and then get excreted again.
Quite a refresher on that life cycle of giardiasis. So, what symptoms do these patients present with other than, diarrhea?
The scary thing is that 50% are asymptomatic. So, yikes. And if they do present with these GI symptoms, whether it's diarrhea, abdominal cramps, greasy stools, weight loss, this occurs after an incubation up to 3 weeks. So this can definitely cause quite an outbreak, I suppose. It's important to remember that the diarrhea is generally not bloody or mucus tinged, and it also typically does not cause fevers.
All right, so how do we make this diagnosis and then eventually treat it?
I think it's important to consider it, right? We have to think about it to be able to diagnose it. So, if a patient is presenting with more than a week of ongoing diarrhea with risk factors for potential exposure, we should think about parasitic infections. The gold standard for diagnosis is getting that stool microscopy, looking for ova and parasite. But unfortunately, this does not have very high sensitivity since the shedding of these cysts is intermittent. And so you do want to generally repeat sampling, kind of in serial days. This is obviously impractical for ED patients, though. You can use immunoassays and rapid antigen tests that are available, but that certainly can be expensive. One thing to note is that the fecal leukocyte test and looking for eosinophils in your peripheral smear, those are generally not useful because they're usually absent. Well, treatment, though, is supportive, including hydration, correcting any sort of electrolyte abnormalities. An antimicrobial treatment is really based on age and generally is either metronidazole or tinidazole. And if you're really worried about other sort of parasitic co-infections, you can, of course, consider anthelmintics.
All right, so moving on away from Giardia to Crohn's disease. How do we approach flares or exacerbations in the ED?
Well, these are generally helpful because patients with Crohn's disease can tell you about their prior presentations and their complications. And so we do want to pay attention to abnormal vital signs, abnormal abdominal exams, like signs of bowel obstruction. Another pearl is to think about secondary infections like C. diff colitis. If the patient is presented with a mild flare, you can consider giving them a steroid burst, or even you can consider giving them a steroid burst. But it is important to discuss with their gastroenterologist if you plan to or want to discuss whether there's any role in adjusting their baseline immunomodulator therapy.
Great point. How about macula diverticulum? How do these patients present?
We've discussed this before. These are generally presenting as lower GI bleeding. It accounts for half of all GI bleeds in children under 2 years old. And this is because that the diverticulum can contain ectopic gastric tissue that leads to ulceration of the mucosa and the blood supply, causing that painless rectal bleeding. Now, patients can also present with bowel obstructions because there could be fibrous glands that connect the diverticulum to the umbilicus. And so, if a patient is coming in or presenting with recurrent or atypical intussusception, that should raise your suspicion for a mecodiverticulum. And then you can also have some inflammation of the diverticulum. And then sometimes they can actually be quite tricky because it can be misdiagnosed as appendicitis.
Great pitfall here that we got to pay attention to. So, how do we make this diagnosis among so many other potential etiologies?
Yeah, I do think this is somewhat difficult because the classic diagnostic tool is to use a mecoscan, or you can even get a mesenteric angiography. CTs, though, actually can be undiagnostic if there is no inflammation, and so it should not be the go-to study in most cases. So if we remember from a prior discussion on the mecoscan, there's the radionuclide is taken up by the gastric mucosa, which can be very accurate in this diagnosis if you are dealing with ectopic gastric mucosa. Obviously, if you're dealing with a diverticulum that is associated with ectopic pancreatic or duodenal tissue, though, this would not make that diagnosis.
Great reminder of the pitfalls of using our usual imaging for this diagnosis. So how is this treated?
Well, we know that, of course, a patient presenting with an active GI bleed will need to be resuscitated before you figure out if they need some sort of surgical intervention like resection of the diverticulum or the involved small bowel. If they're asymptomatic and they happen to find this diverticulum, then it really depends on the length of the diverticulum, if there's other sort of abnormalities that would prompt the surgeon to resect it or simply observe it.
Great summary of such diverse diagnoses. We talked about how with Giardia, 50% of patients are asymptomatic, and we really got to think of it in patients who are coming in with diarrhea, especially after 7 to 10 days of that ongoing diarrhea. Empirically treat or get that stool microscopy with ovine parasites, given that that sensitivity is low due to intermittent shedding. And the treatment is usually to just support the patient with antimicrobial treatment given sometimes as metronidazole or tinidazole. With Crohn's disease, patients are very helpful in letting us know if this is similar to their prior episodes, for which we can give them a steroid burst while working with their GI to discuss adjusting their immunomodulator therapy at baseline. And finally, meckel diverticulum, which is usually a presentation in the pediatric population and quite a common cause for the GI bleeds in those kiddos under the age of 2. We need to remember the limitations of our usual imaging for that. So if you're not thinking of it, we will not be actually able to catch that diagnosis because CTs are not always sensitive for this diagnosis. Well, moving on to a different topic, our drug box this month is about contrast allergy and pretreatment.
The drug soapbox? Well, I say that because certainly, we have a lot of discussions about contrast allergies. A good refresher on the fact that currently we use low osmolality contrast agents, and there's a really low likelihood of adverse reactions compared to the older agents used in the past. When we are talking about contrast allergies, there's a physiologic versus allergic like type of response that people can have. People can have a physiologic reaction that can be more vasovagal, inotropic, or neurologic, and these are generally very benign and can be dose dependent. Whereas the allergic like reactions are thought to be histamine related, and that can result in edema, erythema, stridor, the bronchospasm, etc. The biggest risk factor for a reaction like this is a prior reaction. And so you can pre-treat with antihistamines and steroids, but it's important to remember that still a good amount of patients can have breakthrough reactions, 12% or so.
Great reminder of a topic we talk about all the time. And last but not least, our Tox Box this month is selenious acid toxicity. And that's a chemical used to enhance the color of steel, which is also used in glasswork. Its toxicity is thankfully rare, but ingestions that are as small as less than 1 milligram per kilo can cause severe toxicity. It's quite a corrosive acid, and it can be absorbed either by oral ingestion or dermal exposure. Patients can present with GI symptoms, muscle weakness, such as respiratory failure, and cardiac symptoms, such as prolonged QT and ventricular arrhythmias. If it were inhaled, patients may come in with pneumonitis as well. If you're able to obtain selenium concentration, then please go ahead and do that. But you definitely need to look at their electrolytes to evaluate for hyperkalemia or metabolic acidosis. If there's any concern about oral ingestion, then like we said, it is quite corrosive and they need an endoscopy to evaluate for burns. It is unclear if chelation or dialysis has any benefit in this population, and if they remain asymptomatic 6 hours post-exposure, then they can be medically cleared.
Interesting. I never heard of selenious acid before. Now I know.
Well, thank you, Wendy, for taking the time to go through this issue with me. As always, I have learned a lot. Our dear listeners, we hope that you have enjoyed listening to us as much as we've enjoyed recording this.
We hope that you find the Critical Decisions publication as well as our podcast always informative, often enlightening, and never boring.
We look forward to hearing from you on our social media. My Twitter or X handle is at Tanya Koja.
Mine is at EM_NCC.
And on Instagram, it's at Dr. Tanya Koja.
Mine is at Dr. Wendy Chang.
And until next month.
Bye-bye.